Thank you. My name is Morag Griffin. I'm pleased to be invited to discuss our real-world experience of Pegcetacoplan in paroxysmal nocturnal hemoglobinuria today. I'm the Joint Service Lead for the National PNH Service in the UK. Just a brief overview of what paroxysmal nocturnal hemoglobinuria, or PNH, is. It's an ultra-rare disorder characterised by intravascular hemolysis and thrombosis, with patients often presenting with abdominal pain, hemoglobinuria, dysphagia, erectile dysfunction, or sometimes complications such as renal failure or pulmonary hypertension. Since 2007, treatment has been available in some countries with eculizumab and latterly ravulizumab, both of which are C5 inhibitors, and I'm pleased to say have transformed PNH from a life-threatening disorder to that of a chronic disease. Patients with PNH on a C5 inhibitor can go on to develop extravascular hemolysis, where red blood cells are loaded with C3, resulting in the early removal of by the liver and the spleen, a process of extravascular hemolysis. Whilst this process is not life-threatening, it can significantly affect patients' quality of life, with around a third of patients on a C5 inhibitor needing transfusions and another third being anemic. Pegcetacoplan was originally studied in some pivotal phase 3 trials, in particular in the UK with Pegasus trial, and Pegcetacoplan is now approved in the EU and the US as a C3 inhibitor. It's subcutaneously administered twice a week for patients. Within the Pegasus trial, the mean hemoglobin rise for patients was 23.7 grams per litre, with 85% of them becoming transfusion-free, also while maintaining their LDH control. So their intravascular hemolysis is controlled, the life-threatening side of PNH, whilst preventing extravascular hemolysis. The 3-year data has been presented in 2023 at the American Society of Hematology. We went on to look at our real-world data for patients on Pegcetacoplan within the UK and France, including 2 centres in the UK and a French centre. It was emphasised that some patients within the study were not eligible for the Pegasus clinical trial, either because they were not sufficiently anemic enough to enter the study, or they had comorbidities, or were unable to travel to a trial centre to partake in the trials. These are a slightly different cohort of patients to that included in the clinical studies. We included 48 patients between our 3 centres, 2 UK and 1 French centre, with a total mean time of patients receiving Pegcetacoplan of 20.2 months, with a range of 1 to 52 months. 12 of the 48 patients had participated in the Pegasus clinical trial, with the majority starting treatment after it had been approved. 5 patients were on combination treatment with a C5 inhibitor and Pegcetacoplan. The original indications for patients for C5 inhibitors included hemolysis and thrombosis or thrombosis, and the indications for patients being commenced on Pegcetacoplan was extravascular hemolysis with transfusion requirement or extravascular hemolysis without a transfusion requirement, as per licensing regulations within the UK and France. I would emphasise that patients on eculizumab prior to commencing Pegcetacoplan, there was 22 patients on the standard dosing at 900 milligrams bi-weekly, but 4 patients were on a higher dose at 1,200 milligrams and 2 patients on an even higher dose of 1,500 milligrams, with 1 patient on 1,800 milligrams, all bi-weekly. 16 of our patients were on ravulizumab as well, and 3 patients had transitioned from other complement inhibitors. Mean LDH at the start of Pegcetacoplan was 0.82 times the upper limit of normal, and 3 months after starting Pegcetacoplan was 0.82 times the upper limit of normal. So emphasising maintenance of LDH control and therefore maintaining their intravascular hemolytic blockades and the life-threatening side of PNH being controlled. Mean hemoglobin at commencement of Pegcetacoplan was 91 grams per litre, ranging from 62 to 122 grams per litre, with a mean hemoglobin 3 months after Pegcetacoplan commencement of 115.8 grams per litre, resulting in a mean hemoglobin change of 22.3 grams per litre, very similar to that of the Pegasus study. Mean reticulocyte count at the start of Pegcetacoplan was 205 times 10 to the 9 per litre, again with the majority being elevated, in keeping with the process of extravascular hemolysis. 3 months after pegcetacoplan had commenced, the mean reticulocyte count had reduced to 107 times 10 to the 9 per litre. PNH clone, red cell clone was available for 27 patients within the data cohort, and 23 of these patients had red cell clone availability at follow-up with a mean red cell clone of 84 point, sorry. PNH red cell clone at commencement of pegcetacoplan for 27 patients was 59.3%, which increased to 84% with a mean percentage increase of 19.5% on pegcetacoplan. This is a reflection of the process of cessation of extravascular hemolysis, meaning the red cell clone matches that of the white cell clone. We went on to look at breakthrough hemolysis events characterized by a rise in LDH to near that or that of 2 times the upper limit of normal. 13 patients out of the 48 experienced 32 breakthrough hemolysis events on pegcetacoplan. Some of these were within the Pegasus clinical trial. We went on to report 6 patients experiencing 18 acute breakthrough hemolysis events outside of the clinical trial setting. 38% of these events were associated with a complement activating condition such as vaccination or infection, with the remainder having an unidentified cause. With a mean LDH rise from 1.1 times the upper limit of normal to 5.4 times the upper limit of normal, this is a clear breakthrough events episodes. Within the paper, we've included a clear table of each event and the action that was taken. We went on to develop an algorithm for management of breakthrough hemolysis for patients on pegcetacoplan, which is included both in the tweetable visual abstract and within the main manuscript. We have 5 patients on combination treatments. I would emphasize that this is a very small number of the total number of patients, and there's clearly some patients who require a dual complement inhibitor, although identifying these patients is not possible prior to starting pegcetacoplan, and the reason for this is unclear at the moment and an area of ongoing research. I would emphasize that any patient on a complement inhibitor, irrespective of that type of complement inhibitor, is at risk of a breakthrough hemolysis. It's important to educate clinicians and patients about the issue. These events need to be managed proactively, and in the majority, irrespective of your management of the breakthrough event, most patients can stay on their complement inhibitor event with the acute breakthrough event managed. For example, with pegcetacoplan, either an IV dose at 3 daily consecutive doses or a single C5 inhibitor dose, with patients proceeding with ongoing pegcetacoplan after the event. I reference you to our longer paper, but we present the largest real-world cohort of patients on pegcetacoplan, published very soon after the completion of the clinical trials. Pegcetacoplan is an effective proximal complement inhibitor for patients with PNH experiencing extravascular hemolysis, and we look forward to further long-term data being published. I think there's always options for more research. I think we are aiming within the PNH sphere to have a treatment option suitable for each patient and their lifestyle. So we now potentially have intravenous, subcutaneous and oral treatment options, combination treatment options, and new clinical trials coming forwards. I think in terms of further research, why patients have breakthrough hemolysis, particularly if there's not a complement activating event, needs further research, and as well patients who need a dual combination treatment of complement inhibitor, certainly identifying these patients and looking into why they need this is an area for future research, and potentially they particularly like these C5 polymorphisms that people in the Far East have. There may be other underlying polymorphisms within the complement cascade that we can certainly investigate and will likely come to light in due course.